This presentation on Chapter 17, Blood, will be the last of 5 presentations covered on the next exam. That third exam is going to cover again muscle physiology, Chapter 9. Is going to cover the cardiovascular system and the heart, Chapter 19, and this presentation on blood, Chapter 17. You know quite a bit about blood already, so please review some of the background information. What I'll be focusing on today will be blood clotting, the coagulation cascade, as well as identifying the different white blood cells and learning more about red blood cells and all the other formed elements that are found in blood. We'll also spend some time looking at a couple of disorders as well as the proteins that are found within blood. So you know that the blood is being pumped around by the heart, of course, through the vessels, and that blood is a connective tissue. That means that it's loosely packed cells. Think red cells, white cells. It is surrounded by a ground substance. In this case, it's a liquid ground substance called plasma. And in that plasma, there are certainly proteins that are dissolved. Blood has many, many functions. Not only is it transporting oxygen and CO2, but it's also transporting nutrients, hormones, and metabolic wastes from all of your tissues. It's also very, very important in maintaining, obviously, oxygenation to vital organs like the brain, the liver. It's also very important in your urinary function when you think about the kidneys are filtering out metabolic wastes. We'll spend some time when we get to the urinary system discussing more about how pH is regulated in the blood with the help of the kidneys. And we'll also be dealing with today how blood helps to restrict fluid loss at injury sites in the blood clot and coagulation pathways. Your white blood cells have a large part of your immune system. Some of the cells are phagocytic, others are a big part of fighting off possible infection with virus or bacteria. And obviously blood is helping to stabilize your body temperature as it distributes heat around your body. That is review. The fact that blood is a connective tissue should also be a review. How much blood you have in your body. Males have between 5 and 6 liters, whereas women will have 4 to 5 liters. The difference is just average, based upon average body size. That's not to say that some women wouldn't have more blood than some men. Whole blood would be everything found in your blood. If you go to the blood bank and give blood, you're giving whole blood. And whole blood is going to have a temperature about 1 degree Celsius warmer than your body temperature. It's more viscous than water, and that viscosity comes from dissolved proteins and the formed elements, that is your red cells, white cells, and platelets. It is slightly alkaline with an average of about 7.4. The blood can be fractionated out in what's called a hematocrit. Recall that hemato refers to blood and crit to separate. And by using a centrifuge and taking whole blood, you can pellet out the blood. And what you'll see is that most of the formed elements, 99% of them, are red blood cells. They're going to pellet toward the bottom. And that's going to account for somewhere around 45% of the overall blood volume. For males, it's going to be somewhere around 47% average, from 40 to 54, and women slightly lower, about 42% average, with a range as low as 37 to 47. And when we get to the lab, we'll do a blood lab, and you'll learn a lot more about hematocrit values. The difference here is that higher levels of androgens, testosterone as an example, do stimulate erythropoietin, which does stimulate more red blood cell production. So with males having more testosterone, you would expect to have more red blood cells. So just to see this graphically, and this should all be review, whole blood taken from the body can be separated out into the plasma and the formed elements. The formed elements, again, on average, about 45 or so percent. of the entire volume. That's going to be made up of a very small percentage of platelets, a very small percentage of white blood cells, the vast majority being red blood cells. The plasma portion is going to be made up of about 7% plasma proteins. Those proteins are going to include albumins, the most common, globulins, think your immunoglobulins, your antibodies, fibrinogen, an important protein in the blood clotting cascade, and other enzymes and hormones. You're also going to have electrolytes, sodium, potassium, magnesium, calcium, organic nutrients, as well as organic wastes. Plasma is about 92% water, 7% proteins, and 1% everything else. And we'll be looking at very, very quickly what those proteins are as a review. The difference between plasma and interstitial fluid, the fluid between your cells, is primarily the difference in the gases. Everything else is largely the same. So the percentages of oxygen and CO2 will differ, as well as the percentage of proteins that cannot cross the capillary walls. So your albumin proteins, your fibrinogen, your immunoglobulins, they are only going to be found within the plasma, not in the interstitial fluid. But the electrolytes and other smaller molecules will be very similar between the plasma and the interstitial fluid. So again, about 7 or so percent protein. And these proteins are large enough that they cannot leave the bloodstream. The liver is going to be synthesizing over 90% of all the proteins that you find in the blood. So the albumins, the fibrinogen, mostly made by the liver. So 60% of all of your plasma proteins, by far the most abundant, are the albumins. This is basically egg whites, if you will. And this is that protein which is largely providing the osmotic pressure or the blood oncotic pressure that I discussed before. So this protein is large enough it cannot leave the capillaries, and it's this protein that is, quote, sucking the water back into the capillaries at the venous side of the capillary bed. The second most abundant group of proteins are the globulins or the immunoglobulins. These are the antibodies that are part of your immune system. Fibrinogen, about 4% of your plasma proteins. This is very much involved with blood clotting. And recall that when the vessels are damaged, the fibrinogen is cleaved to an insoluble form called fibrin, which is a major part of the blood clot. The electrolytes within blood, ones you've heard about before: sodium, potassium, calcium, magnesium chloride, bicarbonate, phosphates, sulfates, all sorts of ions, some of which we have not discussed very much yet, but you've heard a lot about, certainly sodium, potassium, calcium chloride. There are a lot of organic nutrients. These are the molecules necessary for energy. Think lipids and carbohydrates and the building blocks of proteins, the amino acids. And of course, your body is constantly breaking down substances. Urea, uric acid, we'll see those more when we get to the kidney. Creatinine and bilirubin and ammonia, these are all molecules that are waste products that the kidneys will be helping us get rid of, and we'll be discussing that in length later in the course. The formed elements within the blood, platelets, these are a very small percentage and they are involved with clotting. White blood cells, the leukocytes, there are 5 different main types. We'll be learning about them. In lab, you'll also be identifying them in a week or so. So you'll get to know your white blood cells very well, not only for their function here, but learning about their identification under the microscope. Red blood cells, these are the cells you know the best of the formed elements, by far the most common. You've seen them under the microscope. You know that they can respond to hypo and hypertonic solutions. You know that they're able to change their shape as they wiggle through the small capillaries, and you know that they carry oxygen. So take a look at the wonderful diagrams in the Martini textbook, especially if this material is a little bit older for you and what I'm saying is not at the tip of your tongue. Okay, so how are these formed elements made? All of the formed elements, white blood cells, red blood cells, and platelets are all made within the bone marrow. The overall process of making blood is hemopoiesis. Remember that hemo means blood, poiesis is the formation or the making of something. All of these formed elements come from a stem cell called the HSC, the hematopoietic stem cell, and you may also see the word hemocytoblast to describe this cell. That term should speak to you. Hemocytoblast, we know that blast means to germinate or bud from, so that means all of the blood cells are formed by the hemocytoblasts. These cells are self-renewing, they're constantly being made throughout your lifetime, and these cells are multipotent, which means that this one hemocytoblast is able to differentiate to become all of your blood cells, be it your red cells, your white cells, or the megakaryocytes, which form the platelets. The hemocytoblast is going to go down two major roads. It's going to have a big fork in the road, if you will, in its differentiation. It can become either a lymphoid stem cell or it can become a myeloid stem cell. The lymphoid stem cells, easy enough, become the lymphocytes. You'll learn more about the lymphocytes, but these are the B cells that make antibodies, and the T cells that make your T cells, also a very big, important part of your immune system. These are going to begin in the bone marrow and eventually go to your lymphoid tissues, things like the thymus, the spleen, and the lymph nodes. The other major branch of the hemocytoblast are the myeloid stem cells, and they are going to form all of the other formed elements. So these are going to give rise to your red blood cells, but also the neutrophils, the eosinophils, the basophils, the monocytes, as well as the megakaryocytes. So just a quick slide to remind you of this. So in the bone marrow, these hematopoietic stem cells are going to form either the myeloid or the lymphoid lines. The lymphoid will go on to your lymphatic tissues, your B and T cells, and your myeloid will go on to make everything else. So I always remember the myeloid make many or multiple types. The lymphoid only make the lymphocytes. Now there's a progression that occurs, and I just want you to recognize the major idea here, not to dwell on each of the intermediates. But the lymphoid stem cells will eventually become lymphocytes, and they first go through lymphoblasts. That makes sense. These are going to form the lymphocytes. And then there's pro-lymphocytes, and then the pro-lymphocytes become the lymphocytes themselves. Now, what's going to cause these cells to differentiate, to become different from each other, are some stimulating factors, hormone-type molecules that are released, and they are going to help stimulate the formation of these lymphocytes. The myeloid are not much different than that. The myeloid, again, have the ability, though, of differentiating into three distinct different groups. So there are going to be the monoblasts, the myeloblasts, and the megakaryocytes that are going to form. The megakaryocytes will be eventually making the platelets, and then there are pro-erythroblasts. So we see some different white blood cells, we see the megakaryocytes, and we see the erythrocytes all being formed from this one myeloid stem cell. The monoblasts, and we'll see a picture of all this in a moment, but the monoblasts differentiate into promonocytes, and those myeloblasts differentiate into the different myelocytes, and then finally, and we'll see that they become a type of banded cell. We'll talk about that in a minute. And then the proerythroblasts go on to form eventually erythrocytes, going on to erythrocytes. The erythropoietin is important. EPO is an important hormone. It's released by the kidneys in response to low oxygen. And this EPO stimulates the stem cells and develops more red blood cells in the red bone marrow. So why would you make more EPO? Well, if you were anemic, low red blood cell count. If you had decreased flow to the kidneys are going to respond to low oxygen or hypoxemia by releasing EPO. If there was decreased oxygen in the air that you were breathing, either from high altitude or from disease state like emphysema, then you would also make more red blood cells. And also, if there was some sort of damage to the surface of your lungs and your lungs weren't able to do the gas exchange process as efficiently, all of these would trick your body into thinking there wasn't enough oxygen or would result in that. And as a result, your body would make more EPO to try to compensate. The myeloid stem cells are the precursors for the formed elements that three kinds of band cells. We're going to see that there are neutrophils, eosinophils, and basophils. You've heard of each of those, but those cells, we'll talk about banded cells and the neutrophils in lab. And the megakaryocytes, which are going to eventually make the platelets. Finally, the reticulocytes will become the erythrocytes. So let's put this all into one big chart. And what you see is that there's one hematopoietic stem cell, which can go myeloid, I already mentioned that, and that can become a lymphoblast and a prolymphocyte, and eventually your lymphocytes. And there's two main groups of lymphocytes, T cells and B cells. Everything else is going to come from this myeloid stem cell, and it has some choices. It can differentiate to become through the erythropoietin pathway, to become a pro-erythroblast, and then a reticulocyte, and then an erythrocyte, sorry. That's your mature red blood cell. That same myeloid stem cell can, through other hormonal signals, become a megakaryocyte. That is going to bleb off and make the platelets. Or it can become, through different stimulating factors, the progenitor cell for making monocytes and eventually making neutrophils, eosinophils, and basophils. So again, this myeloid makes multiple formed elements, whereas the lymphoid only makes lymphoid cells. Platelets are not cells at all, which is why, rather than calling these collectively the blood cells, you hear the term formed elements. Formed elements refers to red cells, white cells, and platelets. They're not cells at all. They're just fragments, little blebs, little pieces that come off from the megakaryocyte. They're constantly being replaced, and they are critical in blood clotting. So read through about the abundance of these. We'll be memorizing the abundance of these in lab as well. But you're looking typically at around 350,000 or so platelets, and this is per microliter of blood. Okay, so we're talking anywhere from 150 up to 500,000 would be sort of a normal range, and we'll learn about some different numbers in lab. Sometimes you'll find that different sources give you different averages or different normal ranges. Right now we're just learning about the ballpark of this. When we get to lab, we will ask you to memorize those numbers very, very specifically. Again, they're going to get sticky and clump together when there's damage to the blood vessels, and this is going to lead to blood clotting. They're only going to last for about 9 to 12 days. I usually say around 10 days. So around 10 days or so, they're constantly being replaced. They're going to be broken down by phagocytosis in the spleen. Okay, so let's take a look now at the other formed elements. So we're going to be talking about hematology. That is the study of blood and blood-forming tissues and the blood disorders. And a lot can be told from your blood. So when you go to the doctor and they draw blood, they can tell about your heart function, your liver function, your kidney function. There are so many different molecules that are indicated in your blood, as well as your state of red blood cells. Do you have an infection? Do you have a clotting disorder? Hematology is a very, very rich field, and it's amazing how much can be determined by a small sample of your blood when the right tests are done. So why would we take blood, and what kind of tests might we do? Well, we can determine your blood type from that. We determine the types and the numbers of red cells, white cells, and platelets. Abnormal values could and may indicate an underlying medical condition. When you do a CBC, a complete blood count, you're determining your red cell count, your white cell count. You're looking at the size and the shape of your erythrocytes, the indices. You're looking at your overall hematocrit, your percentage of red blood cells in your blood sample. You're looking at the number of platelets, and all of these can indicate anemia, polycythemia, could mention if you had a high number or low number of platelets. There will also be, in that CBC, a differential, if that's done, and that is going to tell you how many of each of the 5 different types of white blood cells are present. And we'll discuss if you have high eosinophils, if you have high neutrophils, if you have high basophils. What does that suggest, and what infection may you have? So here are the numbers from a CBC. Again, hematocrit, so normal 42%. Your hemoglobin levels, I haven't given you normals for that, but 14.9 grams per deciliter would be normal. The MCH, the MCV are the indices. They're going to tell you about the volume of the average cell, and also the number of overall health, if you will, of the red blood cells. The number of platelets per millimeter cubed. Now, millimeter cubed is equal to 1 microliter. It's going to tell you the number of red blood cells you have per microliter, the number of white cells you have per microliter, and here you can see that it has done a differential and told you that in this particular blood, 67% were neutrophils. That's normal, most numerous of your white cells. Lymphocytes at 25%, that's normal. Monocytes at 3%, that's normal. Eosinophils at 4 and basophils at 1. These are all relatively normal numbers. So by doing the red cell tests, the different indices, you can not only tell the number, but also, again, the size and the shape of your red blood cells, and if the correct number of them are mature. So within your blood, you would want to see a normal number of mature red blood cells. If you saw a large number of immature red blood cells, it also could indicate disease. So what are those different tests? So when you're doing this, and we'll learn a little bit about it now, and you'll learn a lot more about it in a pathophys course, but we're definitely looking at hematocrit, the percentage of your blood made up of red blood cells. If you had an elevated number of red blood cells, we would say you have polycythemia, a high number. If you had a low number of red blood cells, you would be anemic. We would also look at your hemoglobin concentration, and if the hemoglobin concentration was elevated, again, you would have polycythemia or anemia if it was low. There is a normal concentration of hemoglobin that you should have. And if you have a high number of hemoglobin molecules, then you'd be hyperchromic. Now, hyper meaning high, chrome meaning color. Heme, the iron-containing group within hemoglobin, is it's a pigment. It's what makes your blood red. And so if you had a high number of hemoglobin molecules, hyperchromic means that your red blood cells would be in greater color. They would be paler in color, hypochromic, if the number of hemoglobin molecules was low. The mean corpuscular volume, the MCV, is the average volume of one red blood cell. If it's big, the cells are larger than they should be, so they're considered macrocytic. If they're smaller, they're microcytic. The overall number of cells, again, if the number is high, polycythemia, low, anemia. You may also see the term erythrocytosis, a high number of red cells. And finally, the reticular count. You should have a relatively low percentage of the maturing cells. And so if you have too many of the maturing reticulocytes in your blood, you would have reticulocytosis, a high number of these reticulocytes. And if you had a depressed number, then you would have perhaps a sign of diminished erythropoiesis. So a lot can be told about your overall health from these red blood cell counts. Roughly 1/3 of all the cells in your body are red blood cells. Okay, so it's just an astronomical number of cells. A single drop of blood will contain 260 million red blood cells. So you have in your body about 25 trillion of these cells. Okay, and again, the numbers. Now, this is the actual number of cells. So 4.5 to 6.3 million red blood cells per microliter. That's going to be your average number for males and lower for females. Notice the numbers do overlap. The females 4.2 to 5.5. This is different from the hematocrit. Hematocrit is the percent of red blood cells. This is the raw number. So how many you have per microliter, that's just your cell count, versus hematocrit, which represents the percentage of your blood which is made up of red blood cells. So if you just took a look at blood under the microscope, right, you would just have this smear. Most of these cells are just good old red blood cells. The little tiny fragments are platelets. So these little fragments you're seeing are platelets. Now you know what a red blood cell look like. You know that they are biconcave. That means they have two indentations. They have an average of 7.5 to 8 micrometers. They do not have a nucleus, so they're anucleated. They're lacking most of their organelles, including ribosomes, so they can't divide, they can't repair themselves, they can't undergo mitosis, and their lifespan is around 120 days. So here you see the dimensions. You've seen red blood cells before. Typically, that last slide said 8. This is giving you a range of 7.2 to 8.4 micrometers. A good number to keep in mind is 7.4 micrometers. That's the most common value that you will see for the diameter of a red blood cell. They have a very large surface area to volume ratio because of that biconcave shape. And because of that, they can carry more oxygen molecules. They can form stacks called rouleaux, and this is going to allow smooth transport of the red blood cells, sort of in a row, stacking up in a row, going through the small vessels, and are very, very flexible. In this image, you can see the vessel here, and you can see how these red blood cells are stacked up almost like poker chips. Hemoglobin, very, very important for transporting oxygen. Oxygen itself does not dissolve very well in plasma. So in order to facilitate the uptake and the transport of oxygen, hemoglobin is critical. So without hemoglobin, oxygen does not travel well through plasma at all. So most of the red blood cell is filled with hemoglobin. That is by far the most, the highest percentage of all the proteins within a red blood cell, and they account for a large number. So the grams of hemoglobin per deciliter, pretty substantial, right? A lot of hemoglobin in your red blood cells. So what does heme look like? This is a heme molecule. So this heme molecule, you're seeing this little, looks like a little disc. And that little disc, the little red circle of it, is an iron molecule. So you see that there are 4 heme groups. And this is hemoglobin, the whole molecule. And it's actually made up of 4 parts. There's an alpha, and a beta, and a beta, and an alpha. And those 4 parts make up one hemoglobin molecule. And to each of those heme groups, here's 1, 2, 3, and 4. to each of those, an oxygen can bind. And you have millions of these hemoglobin molecules in each and every red blood cell. So again, 2 alphas and 2 betas. In the center of each of those alpha or beta subunits is a heme group. That heme group is a pigment. That's what gives the bright red color of blood when it is fully oxygenated. So every hemoglobin can handle 4 oxygens, and when oxygen is bound to hemoglobin, it will appear a bright red. When there's less than 4 oxygens bound to the hemoglobin, the blood will not be quite as bright, will instead be more of a darkish brown brick red color. So again, here's that picture in larger size, and each of these little cylinders is a heme group with a little iron attached to it in the center. That iron group's very, very important. If you have low iron, you're also anemic. So if you don't have adequate iron in your body, that means that your hemoglobin cannot be fully activated, and you would also be anemic because oxygen cannot bind if there aren't enough iron molecules to go around. So here's the idea that when oxygen is bound to hemoglobin, we call it oxyhemoglobin. You'll see HB, hemoglobin, with oxygen bound to it. That's going to give your blood a bright red color. And this oxygen can quickly come off and become deoxyhemoglobin, and that has a darker red color. So again, here's the heme group, not responsible for the chemical nature of this. In the very center of it is the iron, Fe2+, is the iron species to which the oxygen can bind. So each and every one of your red blood cell has about 280 million hemoglobin molecules. Remember, each one can handle 4 oxygens. So every red blood cell can carry more than 1 billion molecules of oxygen. It's amazing, right? So only about 1.5% of your oxygen is dissolved in the liquid plasma. 98.5% of your oxygen is in fact bound to and carried by the hemoglobin through the plasma. So about 1% of your red blood cells are being replaced every day. 3 million new red blood cells are entering your circulation every second. This is an amazing process, right? This is the most abundant cell in your body, and they're being replaced since they have a span of less than 120 days. So we're talking about a very rapid replacement. These cells that are breaking down are going to be engulfed by macrophages. Those macrophages are in the spleen and the liver, or even the bone marrow. So again, as a review, we have erythropoiesis, the making of red blood cells, happening in the red bone marrow. Remember, red blood cells are coming from the myeloid side of the hemocytoblast. And where are you actively making blood as an adult? Where do you still have red bone marrow? And that's going to be in your vertebra, your ribs, your sternum, your skull, the flat bones of your skull, the scapula, the pelvis, and the proximal humerus and the proximal femur. So primarily, it's the flat bones, the irregular vertebra, and the long bones of the upper arm and upper leg. As a young person, there was a greater percentage of bone marrow in your blood, or sorry, in your bones. And as an adult, most of that's been replaced by yellow bone marrow, mostly fat. But that yellow bone marrow can revert back to red bone marrow if there is a loss. And so if your body needed more red blood cells, the yellow bone marrow can come to the rescue. And the yellow bone marrow is also useful in bone marrow transplants. So in a similar story, as we just barely talked about before, there are developing red blood cells in the bloodstream. and they're going to go through a number of stages. Remember, they're made in the bone marrow, and then they're going to travel through the blood. And you have erythroblasts, sorry. Then the cells go through a basophilic stage, and they begin making a lot of hemoglobin. They then eject their nucleus. Remember, these are anucleated. That's called a normoblast. The normoblast loses its nucleus, I should say, to become the reticulocyte. And the reason it's called a reticulocyte is it still has endoplasmic reticulum. So you can still see sort of a granular appearance within the cell. And at this point, most of the cell is filled up with hemoglobin. It will enter the bloodstream and then eventually become a mature red blood cell. Remember, I told you only about 0.8% of your circulating red blood cells should be these less mature reticulocytes. So again, here we are, head of the humerus, definitely some red bone marrow in here, and we're making the proerythroblasts and going to the basophilic stage. Then the normoblast, you see, still has a nucleus. The nucleus is ejected, and now we have a reticulocyte. The reticulocyte will then become a mature red blood cell. Notice the pathway here. This takes about 5 days. Okay, about 5 days. And then the red blood cells are going to circulate for about 120 days, and eventually will be broken down in the spleen, the liver, and the bone marrow. They'll be basically hemolyzed, broken down, and this is the process of hemolysis or hemolysis, in which case the hemoglobin molecule will be removed and the iron will be recycled. It'll be released in the bloodstream and travels back on a protein called transferrin. All right, it's transporting, transferrin. Remember, Fe is iron, ferric. So transferrin is a protein, IN, that transfers the iron through the blood. And it'll be recycled and reused again. The hemoglobin will continue to be broken down. Some of it will be broken down for amino acids for other uses, but you probably heard of bilirubin. And heme will be broken down into biliverdin and bilirubin and eventually go to the bloodstream. And if a large number of red blood cells are broken down at once, this can result in the urine becoming colored. In fact, this breakdown of heme is what gives your feces their brown color. And if a large number of red blood cells are being broken out at the same time, then the urine can also become dark. And that'd be called hemoglobinuria, in which case you have hemoglobin appearing in the urine, urea. So looking at what happens here, macrophages in the spleen, the liver, and the bone marrow are going to break down, hemolyze these red blood cells. The iron will be captured and transported back to the bloodstream and used to make new red blood cells and new hemoglobin. The heme group will be broken down to biliverdin and bilirubin to give color to feces, as well as be a breakdown product of this heme group. So the bilirubin is released from the macrophages. It binds to this protein called albumin, the most abundant protein in your blood. It's transported to the liver for excretion in the bile, and that's how it ends up. The bile, you see the word bile. It is a protein that is going to definitely be released through the feces. If bile accumulates in the peripheral tissues, that can cause jaundice, and jaundice can cause a yellowing of the eyes and the skin. Some newborns will have a form of jaundice. Jaundice is also a sign of liver damage if the liver is not keeping up with the breakdown. So if for some reason the liver is failing to break down everything properly, then the person can start having a discoloration of the eyes and the skin. And you've heard of cirrhosis, right? Cirrhosis of the liver. Cirro, in that term, refers to the yellowing. And again, the bacteria are going to convert the bilirubin to molecules or with the specific names, but they're going to become the yellow of the urine will also become the brown of the feces. Now, there's also events occurring in the kidney. The kidney will be excreting some hemoglobin, not very much, a little bit. So that's going to give your urine its yellow color. And typically, you would never see intact blood in your urine. If you do see urine in your blood, it's typically after there's been some sort of damage or infection to the urinary tract. So again, bilirubin, broken down by the macrophage will be released and be excreted in the bile. That bile will go into the colon and will be eliminated in the feces. And some of those molecules are absorbed in the bloodstream, which will show up to the kidney and be eliminated in the urine and give urine and feces both their color. So putting it all together, take a look at this image. You can see that, again, we're talking about just the synthesis of the cells. After about 120 days or so, those red blood cells are broken down. Again, the iron is recycled. The heme is going to be converted to bilirubin, liver, feces, and some of it in the kidneys as urine. Blood typing is something you should be familiar with. I'm going to fly over this very, very quickly. Blood typing, I want you to be responsible for in Biology 106. It's something that you should already know. And I think it's important enough to go back and review this. Remember that blood typing, the most common blood typing, is based upon the ABO system. And there are lots and lots of antigens on the surface of your blood cells. But of particular importance are A, B, and the Rh factor. Rh factor gets its name. It was first described in rhesus monkeys, and you'll also sometimes call it antigen D. So these are genetically based. You inherit these from your family, but there's type A, surface antigen, type B. They can both be present, in which case you have AB blood, and they can both be absent, in which case you have type O, or the absence of the A or B antigens. Typically, your body would only make antibodies against the blood types that you do not have. So if you have type A blood, you would have surface antigen A on the surface of your red blood cell, and your body would produce anti-B antibodies, something that it does not have. If your body was to see or to have B blood put into it, these antibodies would quickly detect, clump, and bind to that to eliminate that foreign blood. If instead you inherited type B antigens, you would have type A antibodies. If you inherited from both of your parents the A and the B, you would have both of these antigens on the surface, and you would make neither antibody. And if you did not inherit either, you would have naked little red blood cells, type O, and you would make antibodies against both A and B. Now, if you receive the wrong blood type, then the antibodies that are present will clump or agglutinate with the surface antigens of the foreign blood, and this can be a huge problem. The idea is that eventually those foreign blood cells will undergo hemolysis. The problem is that hemolysis takes a little while to occur. In the meanwhile, you can be producing dangerous clumps or fragments of these hemolytic masses, and that can block blood supply or even damage tissues, and can even be life-threatening if there's enough of the wrong blood put into the bloodstream of the patient. So again, if you had antigens on the blood that were recognized by antibodies, they would clump as a mass in agglutination. They would eventually be hemolyzed, right? They're going to be destroyed. That's the idea. When the antibodies attach to those foreign cells, it's going to set up a destruction pathway. But this is the problem, right? It takes a little bit while for this hemolysis to occur. In the meanwhile, your tissues are being blocked, and the blood flow is being blocked by these agglutinations. The other Rh antigen, another important one, gives you either the positive or negative indication in your blood type. So fully, your blood type is described as being A positive or A negative, O positive or O negative. The negative comes from the absence of Rh. The positive comes from the presence of Rh. Now, this is an interesting breakdown. Again, these are averages in the U.S. of different racial groups and the percentage of blood type. So you can see that there's some significant differences. In the average person in the U.S., AB blood is rather rare. 85% of the country is Rh positive. Okay? But notice Chinese Americans, Filipino Americans, Hawaiians, Asian groups, pretty much all Rh positive. And if you look, Japanese American, for example, have a much higher, Korean and Japanese group have a much higher of AB. And other groups like Hawaiians have a lower percentage of the B type. So this is just a sort of a curious chart to look at. Notice too, if you look at native South Americans, almost all type O, right? They're all almost O positive. Whereas Australian Aborigine, right, you would see about a split of O and A, no B at all. No B and therefore no AB. And also mostly Rh positive. So nothing can be proven based upon this, but if a blood sample was found, it could suggest race. It certainly couldn't prove race, but blood typing might suggest race of the perpetrator, or perhaps in a paternity case, but it cannot prove paternity. So you've done blood typing in 105, so I'll jump over that. You can read through as a reminder of how to do blood typing. You also were introduced to hemolytic disease of the newborn. That is a cross-reactivity of the mother's antibodies with the fetus. And this can happen. The Rh antibodies, it's possible for them to cross over the placental barrier. Anti-A and anti-B antibodies do not cross the placenta. This is only a case of the Rh antibodies. And if the father is Rh positive and the mother is Rh negative and the baby is also Rh positive, so here's the problem, right? If the mother's Rh negative, the father's Rh positive, and the fetus has inherited that as well, then the mother's antibodies can cross the placenta and attack the baby's red blood cells. And this can be from minor to being very, very severe, and can definitely be a cause of miscarriages. Now, during a first pregnancy, it's usually not a problem because the mother has very few cells. But upon birth and during the pregnancy, some of the baby cells are going to, and those antibodies are going to cross over. So the bleeding of the placenta and the uterus is definitely going to expose the mother to significant Rh antigens at the time of birth, and the mother will then be sensitized. It's almost like she's been vaccinated with or against Rh. So when the next child comes along that is also Rh positive, right, then there can be some problems. Now, about 20% of Rh negative mothers who carried an Rh positive child are sensitized within 6 months of delivery. So the first baby, no problem, because the mother had not yet developed antibodies. The problem is the next pregnancy where there is an Rh positive infant. The second and third child, if they were Rh negative, would not be a problem. It's the next Rh positive child. And what happens, again, is that the maternal anti-Rh antibodies cross over the placenta, enter the fetal bloodstream, and start destroying the baby's red blood cells, causing anemia. And this can lead to a problem with dropping red blood cells. And what happens is this can be a really high fatality rate. If the baby does survive, then the newborn can be quite anemic and quite jaundiced because the body's been trying to make more red blood cells because they were being destroyed. the maternal antibodies will remain active 1 to 2 months after delivery, and so the baby may need to get a transfusion after birth. And typically now, Rh negative mothers are given RhoGAM. Okay, they're going to be given it midway of pregnancy and then again during and after delivery. And what the RhoGAM is, it's basically antibodies that are going to not allow the sensitization. So it's going to disallow or block the mother's ability to make the antibodies against the Rh factor. So this story, this picture is too small for you to see here, but it gives you the whole story. And that is, here's the Rh negative mother, the Rh positive fetus, and first baby, everything's fine. But the subsequent baby, the antibodies can cross over at the placenta and attack the baby's blood. So that's everything I want to tell you about red blood cells. Let's start talking about white blood cells. White blood cells are the leukocytes. They spend only a short time in circulation. Most of them are going to be in your loose or dense connective tissues where infection can occur. And they can migrate out of the bloodstream and go to where the site of infection is. So they'll undergo what's called emigration or diapedesis. That is, they'll move and squeeze through the endothelial cells into the tissues wherever the infection is. They're going to be drawn to the site of infection through chemotaxis. Chemotaxis is basically the cells are going to respond to chemical signals and move toward taxis, movement, are going to move toward those chemicals. And some of these cells are capable of phagocytosis. They're the neutrophils, the eosinophils, and the monocytes. They're capable of phagocytosis, and they can literally engulf a pathogen, a bacterium or a virus, or other dead and dying cells. And macrophages, you've heard of more of. Monocytes, macrophages are the monocytes. Once the monocytes have moved out of the bloodstream, now they pick up the term macrophage. So the numbers here are not as dramatic. There were millions of red blood cells per microliter. On average, your blood has about 7,000 white blood cells per microliter. We're going to say that 5,000 to 10,000 is normal. So that's going to be our normal range. 5,000 to 10,000 white blood cells per microliter. The number can certainly increase if you have an infection, and if you have high neutrophils versus high basophils or high eosinophils. That can also tell us perhaps about what kind of infection or allergic response you're having. So there are two main groups of white blood cells. There are the granular leukocytes or the granulocytes, and they simply have a granular appearance in their cytoplasm. Those granules that you're seeing are filled with proteins and different chemicals. The neutrophils make up 50 to 70% of your white blood cells. All of them together, by far the most numerous. They have little granules, but they're rather neutral in color and may not be that obvious. Eosinophils, they stain with a dye called eosin, so they become very pink in color. And basophils are very blue or black in color. And they're the most rare of the white blood cells. I always say their numbers are in the basement. They are blue-black, and those are called the basophils. So BBBB. Basophils, blue-black basement. Then the other ones are the agranulocytes. This is going to include the monocytes. They're going to account for between 2 and 8%, and the lymphocytes somewhere in the 20 to 40% of all of your white blood cells. Again, we'll be giving you standard numbers in lab. So when you look under a blood smear, you're going to see primarily red blood cells. There are going to be larger, colorful cells. The color is not natural, it is but from staining. And here all 5 of the white blood cells are obvious. And we'll be looking at each of these and learning about them now and again in lab. The ones that have the granules, the neutrophils, eosinophils, and the basophils. The ones without the granules are the monocytes and the lymphocytes. Please read through these charts. It will give you their average numbers. For now, what I want you to know for sure are their average ranges. 50 to 70, 2 to 4, less than 1%. I want you to be able to recognize them. Again, we'll be practicing this in lab. Again, very pale granules, very bright red granules, and dark blue or black colored granules. And what are they doing? Neutrophils are there. Their specific job is to engulf and destroy bacteria. So a high number of neutrophils would indicate a bacterial infection. Eosinophils are also phagocytic, and they are specifically going after parasitic infections. And finally, the basophils are entering damaged tissue, and their job is, one of their jobs is to release histamine, and histamine is going to promote inflammation. Inflammation means the tissue is going to get warmer, more blood flow, it's going to get swollen, and it's going to allow more of these cells to come to the site of the infection. The monocytes, again, what I want you to know for now are their ranges, their normal ranges. Be able to recognize them. Monocytes are monstrous in their size. That's why I remember them. They're monstrous in their size. The lymphocytes look like little eyeballs looking back at me. They have very little cytoplasm, so they have a big nucleus with not much cytoplasm around them. Monocytes are also engulfing and getting rid of debris. Lymphocytes, again, these are your T and B cells, and they are making antibodies and directly destroying cells. So let's talk about hemostasis. Hemostasis is basically blood clotting. So what is the pathway of stopping blood? If there is any kind of damage to the wall of the blood vessel, that is going to set up a cascade of events, which is going to be broken down into three parts: vascular phase, platelet phase, and coagulation phase. In the beginning, in the vascular phase, about 30 minutes after injury, the endothelial cells are going to contract. They're going to expose their underlying basement membrane, and those endothelial cells that make up the inside of the blood vessel are going to start releasing chemical factors, hormones, and molecules called endothelins. These molecules are going to stimulate smooth muscle and promote spasms. They're also going to stimulate division. Think we need to start repairing the damage. So we're going to start making more endothelial cells. We're going to start making more smooth muscle cells that are also found in vessels, and the fibroblasts that make the collagen. So all of this is to accelerate the repair process. The endothelial plasma membrane will become sticky, and any kind of tear again in an artery or a vein, and what's going to happen is that the stickiness of the plasma membrane is going to allow or facilitate the attachment of the platelets. So if you were to cut the vessel, again, any kind of damage, you're going to see a spasm. The smooth muscle is going to squeeze, and that's going to, as you can imagine, reduce the blood flow to try to preserve the blood. And we're going to start making more cells, and we're also going to start making it so the platelets are sticky. In the second stage, the platelets are going to begin sticking very well to the endothelial surface, to the basement membrane, to any exposed collagen fibers, and the platelets themselves are going to start releasing chemicals. They're going to release ADP, which is going to stimulate more aggregation of the platelets. They're going to release platelet factors and platelet-derived growth factor. All of these are going to promote vessel repair. and calcium. Remember we talked about how calcium is important not only in action potentials and nerve propagation and muscle contraction, but also in blood clotting. So now you see where that calcium plays a role. So in the platelet phase, we've already cut the vessel. The platelets are beginning to aggregate and get very, very sticky. And they're releasing chemicals, calcium, platelet-derived growth factor, and ADP, which are also going to help in the cascade of healing. Finally, there's a coagulation phase of hemostasis, and this is going to be starting about 30 seconds or more after damage. The coagulation, the blood clotting, is going to be a whole series of steps. But recall that the third most abundant group of proteins in your blood are the fibrinogens. They account for about 4% of your blood proteins. Fibrinogen is soluble. It's dissolved in your blood. But one of the steps here in the coagulation series is that fibrinogen will be changed to a smaller insoluble protein called fibrin. Now fibrin now is going to start collecting like a web and getting red cells and white cells and platelets to create a web. And there's also going to be a whole series of enzyme steps that involve calcium and other proteins that are going to activate through a cascade a chain reaction that is going to create the blood clot. Now there's two different phases for this coagulation, or two different pathways, and they both lead to the common pathway. There is the extrinsic pathway. This is going to release with tissue factor. Tissue factor is also called factor 3. This is released from the damaged endothelial cells. The more damage, the more of tissue factor that is released. Tissue factor will combine with calcium, and that will now make factor 10. And factor 10, as we'll see, is the first step in the common pathway. These numbers, these factors, are numbered using Roman numerals, and they are numbered in the order in which they were discovered. That does not mean the order in which they actually work. So these numbers are not in order of how they work, but instead are in the order of their discovery. And like so many things in science, it'd be so much better if they all just agreed to wipe the slate clean and go, okay, step 1, just have factor 1, goes to factor 2, goes to factor 3, goes to factor 4. But that's not how science works, and so we will see that these numbers are out of order. Now the other side of the hemostasis, the coagulation phase, is the intrinsic pathway, and this is going to start off by activation of enzymes that are exposed to the collagen at the site of injury. And this pathway proceeds with PF3, a factor released from the aggregating platelets, and that also leads to factor 10. So we're going to see that factor 10 is the beginning of this, and that is the common pathway. So the common pathway begins with factor 10 I should say, and that is going to convert prothrombin into thrombin. And thrombin is the molecule that is going to convert fibrinogen into fibrin. So we need to have that fibrinogen to fibrin conversion with the help of thrombin for this whole thing to happen. Now, once you have stopped the blood, right, we don't want that blood clot to be there forever. So at some point, once the body has stopped the flow of blood, they're going to have to retract the clot. And so there will be, after a while, a retraction of the clot and then a breakdown of that blood clot. So again, here what we see is that there's the extrinsic and the intrinsic pathway, and they both lead, as you can see, to factor 10. And factor 10 then brings us to this prothrombin to thrombin. Thrombin is necessary to convert fibrin into fibrinogen to continue the clotting process. Now, once you have that clot formed and blood has been stopped, you do want to break down that fibrin clot. So fibrinolysis, the breakdown or the lysis of the fibrin, this is the dissolving of the clot. And in order for this to happen, plasminogen is activated to plasmin. And this is going to happen through a protein called thrombin. And you may have heard of TPA, tissue plasminogen activator. This is released by damaged tissue. This is also used in the clinic. If a person goes to the emergency room and they suspect that they have a blood clot and it has been a relatively short amount of time, they may give them TPA, and that will actually help to break down the clot. So we get now plasmin, and that's going to help erode the clot. So that represents the basic information that I want you to know about white cells, red cells, and platelets. Much of its review. What is specifically new is, or are the steps in the blood clotting cascade, as well as the identification and understanding of what the different white blood cells are doing. You should know your red blood cells pretty well. And now let's talk about some different disorders of blood. Well, first of all, how are we going to get your blood? We're going to do venipuncture. That is, we normally withdraw blood from a superficial vein, oftentimes the median cubital vein in the arm, in the antecubital region, and that's the reason is that veins are more superficial. They have a thinner wall than arteries, and their pressure is lower, so they're going to seal and clot more quickly. So most clinical procedures will be looking at venous blood. Now, what can we look for? We can look for anemia. This could be caused by insufficient iron. This would give you small red blood cells that are microcytic, that is, they're small, and because there's not enough iron, they can't transport oxygen well. And this is more common in women, because women have less of an iron reserve than men, and because of the menstrual loss of blood, iron loss is a bigger issue in women than men. There's also pernicious anemia. This is basically a deficiency of vitamin B12. B12, if you have a deficiency in B12, then you won't have normal red bone marrow development. So there'll be fewer red blood cells, and this can lead to larger macrocytic red blood cells. And another reason that this can happen, pernicious anemia, is from a lack of intrinsic factor. Intrinsic factor is a protein made in the stomach and is necessary for absorbing B12 into the bloodstream from the diet. People who have had gastric bypass and whose stomach has been reduced in size oftentimes don't have enough intrinsic factor, and therefore are vitamin B12 deficient and must be on supplements. Clotting disorders can be from insufficient calcium, as we've already mentioned. Calcium is important, but also a deficiency in vitamin K. Vitamin K is required for the liver to synthesize some of the clotting factors. Sickle cell anemia, we talked about this back in the genetics unit chapter of Biology 105. This is a genetic mutation, a point mutation in the hemoglobin. As a result, the red blood cells don't carry oxygen very well. These cells are more fragile. They tend to sickle in their shape, and that shape gets stuck in capillaries, blocking blood flow, and makes it very, very difficult for these patients to get normal oxygenation and normal perfusion of their tissues. Sickle cell anemia, again, those who have one copy of this gene have the sickling trait, but not the whole disorder. And we know that individuals who have only one of the two genes are actually more resistant to malaria. And it turns out that these sickling traits, the parasites are less likely to invade. In this picture, you're able to see the oddly shaped sickled cells. Hemophilia. This is an inherited blood disorder, bleeding disorder. Not that uncommon, more common in males because of its genetic, the way it's passed down through the Y chromosome and the X chromosome. And you're missing one of the clotting factors. So the blood cannot properly clot. So when needed, the blood doesn't clot. So these patients bleed out through small injuries. It can be very, very important. And they can even have bleeding in places where it wouldn't normally occur in you and me. Thalassemia, another group sort of similar to other hemoglobin molecules. Basically, they have other abnormal hemoglobin subunits, and again, it depends upon the severity. There's many different types of thalassemia, but they're also a genetic inherited disorder of the blood. You can have an infection of your blood. Normally, your blood is pathogen-free or bacterial-free. Should you get bacteria in your blood, you have bacteremia, and viremia would be viruses in the blood. If those bacteria get in your blood and begin to divide, then you could have septicemia, which is where you have lots of widespread bacteria in your blood, and this can lead to a very serious infection. And again, this can be tested by drawing blood from you and looking for the presence of bacteria. Malaria, another condition of the blood. This is a parasitic disease caused by a protozoan, Plasmodium. And this is a big killer in the developing world, transmitted by a mosquito. And this mosquito, the larvae of the parasite are in the mosquito. It's infected, goes to, initially infects the liver, but fragments start infecting the red blood cells, and you start getting this episodic rupturing of the red blood cells and release of more parasites. So there's these cycles of fever and chills, and those dead red blood cells can block vessels to vital organs, and that's what can kill patients. Leukemias are blood cell cancers. So any of the cells, these are rapidly growing cells, of course. So, as you know, cancer is simply a cell that has lost control of its cell cycle, and these cells can spread from their bone marrow throughout the body. And what might appear in the blood is an absence of either abnormal or immature red blood cells or white blood cells, whatever kind of leukemia it is. And this can crowd out and destroy the other cells, and these leukemias can be fatal, although they're becoming more treatable if they're caught early. So two different types of leukemias, myeloid and lymphoid. So this tells you a little bit about it. If it's a lymphoid leukemia, you know it's going to be just the lymphocytes or their precursor stem cells. If it's a myeloid leukemia, it's going to be any of the other cells that are made, perhaps the granulocytes or megakaryocytes or the red blood cells. There are also some degenerative blood disorders, DIC, disseminated intravascular coagulation. And what happens is that bacteriotoxins can activate some blood clotting steps, and you can get too much of the fibrinogen converted to fibrin. This will start clotting up small vessels, and this happens with a blood infection. So not only are you septic and you've got bacteria, but some of those bacteria can actually set up and begin the clotting cascade. And so now the liver will and other organs can be damaged by blockage of blood vessels. So that brings us to the very end of the material for exam number 3. And please take a look at the mastering assignments and the quiz that we posted. I would encourage you to get as many of these assignments done before we have our review.